So, good afternoon, friends. Next to this, we started with the introductory classes with the Parkinsonism. We have seen what are various signs, symptoms, and we are going to discuss about various therapeutic approaches for diagnostic as well as treatment approaches. Now, the diagnostic things are there, that is, once we see that any suspected Parkinsonism disease, now what is suspected, we have seen various what we can say prominent signs, that is tremors, rigidity, difficulty, akinesia, etc. So whenever it is there, then we can suspect them and go for stiffness, slowness, balance problem, gait problems. So if it is there, then they are referred to the experts, and these experts should go for the differential diagnosis, what kind of problem the person may be having. Now it should be diagnosed clinically. We have got again various ways for that. We do various tests for that. We know various scales also. We have seen these various scales. On this basis we can go for diagnosis, review the diagnosis, and check the performance after treatment, whether there is any improvement or not, because if it is a Parkinsonism, it should get some good prognosis or some benefits with the treatment. So go for review of diagnosis, and if it is not responding, then as usual, if you see the algorithms earlier, then we go back to our diagnostic process, whether the disease is properly diagnosed or not, and then review the treatment. Now these are various ways, various treatments, various diagnostic tools which are available, and most widely used is single photon emission computed tomography, that is, we call it as a PET scan. So this is a single photon emission computed tomography, that is called as a SPECT. For people with tremor, if essential tremor cannot be clinically differentiated from the Parkinsonism. Essential tremor means some people do have tremor without having any Parkinsonism, just like essential hypertension. So in that cases, this PET will confirm it. It should be then next is another PET. Yes, PET should not be used in the differential diagnosis of Parkinsonism syndrome except in clinical trials. Then MRI should be used in only in a differential diagnosis of other Parkinsonism syndrome. Otherwise it should not be used in a normal situation, because it is unnecessarily, it is a cost inflicted on the patients. So it should not be unnecessarily done. When it is necessary only, should be gone. Same is the case with magnetic resonance, voluntary movement, voluntary activity, volumetry measures for the differential diagnosis Parkinsonism. Only it can be done in clinical trials to review the outcome in a very short period of time. Same is the case with the magnetic resonance spectroscopy. Now few tests are there. If you remember earlier, in pharmacology you might have studied, that is whenever there is a problems, example in myasthenia gravis, it is very commonly known. Whenever the persons were having myasthenia gravis, then the drug like edrophonium is given, which is short acting, and it is given, and if it is giving cure, then it means that it is the person is having myasthenia gravis. And if it is causing exacerbation, then we can diagnose that it is having an Huntington's chorea. So this is how the diagnosis is done. Similarly here, acute levodopa or apomorphine challenge tests are there. Acute administration is done comparatively higher dose and checked, but again it is not it is not recommended by NICE guidelines. NICE guidelines says that it should not be used in that, because already you have got good other techniques, measures to go for the diagnosis of Parkinsonism. Same is the case again. Objective smell testing. NICE is not allowing, or NICE is not recommending to use objective smell testing in the differential diagnosis, except in the clinical trial. Again, in clinical trial, one can go for that. Now, pharmacological treatments, we know there are several drugs are available. We know that there can be several situations, comorbid risk are there, and therefore polypharmacy, whenever there is more than one type of drug, then it should be used very cautiously, carefully, and in that cases we should be aware about various drugs, their effectiveness and the problems. So from the basic knowledge of pharmacology, we understand it, and we can have this tabulated in a form. So particularly when there is a motor syndrome, which are more prominent one, or it is in initial stages, we have seen if it is gradually increases, then it goes into other neurological symptoms or psychiatric symptoms. So initial stages, these are the motor symptoms, and for motor symptoms the drug of choice is levodopa. Let us compare various drugs which are recommended for that, and accordingly we can decide. So whenever there is a motor symptoms, we can have levodopa. If we give, then it is having more improvement in the motor symptoms comparative to that of dopamine agonist and MAO inhibitors. If we see the daily activities of the person, we can say there is a much more improvement in activities with levodopa than dopamine agonist and monoamine oxidase. If we see about motor complications, here motor complications comparatively are more. Now, what are these motor complications? Again, it is rigidity like activity after drug treatment, and on and off phenomena, which is very common. If you have studied the pharmacology, you may remember this on off phenomena with L-dopa. So it has got more motor complications, while the dopamine agonist and the MAO inhibitors, they have fewer motor complications. Adverse events, there are many adverse events are available, are known for which are to be caused by various anti-Parkinsonism agents, and example of these are excessive sleepiness, hallucinations, impulse control disorders. So these are various adverse effects, again motor impact and adverse effect on various systems. So the L-dopa has got comparatively lesser side effects than the dopamine agonists. They have comparatively more specified adverse effects, and the last class, that is MAO inhibitors, they are comparatively again lesser. But if we will make the sequence, then L-dopa is having minimum 1, so the MAO inhibitors are having slightly more than that, and the dopamine agonist will have comparatively more than it. Now, as usual, we have seen it, and we have reiterated at many times that particularly drugs which are used in various CNS conditions should not be withdrawn abruptly. It should be given some time. We should be having a tapering of doses, or some alternative has to be done. So it has to be maintained. All of a sudden, if because of any reason the plasma concentration is going to be decreased, then it has to be planned accordingly. The drug holidays is a very important concept that is used particularly with levodopa, that is because of on and off phenomenon. It is recommended in pharmacology books that for that this should be given some drug holiday, or around 2 to 3 days. So it should not be undertaken. The NICE guideline says, NICE guideline do not allow or do not recommend it. So this is very important. These are the important changes if we compare it with the pharmacology. In pharmacology, we will find that the biggest problem with levodopa treatment is on and off phenomenon, and for that it is recommended that the drug should be stopped for some time. We call it as a drug holiday. So this drug holiday around 1 to 3 days it is maintained. but it is says that it should not be undertaken because of the risk of neuroleptic malignant syndrome it can cause, and therefore there should not be such kind of situation. Whenever there is sudden change in the anti-Parkinsonism drugs, people with the Parkinsonism disease who are admitted to hospital care should have their medications at appropriate time, and it should be adjusted by experts or specialists for various doses, considering if there are more than one kind of drug, then whatsoever impact each other causing, we know drug interactions, then it should be there. So on that basis, we have seen this comparison above. So on that basis, the first line treatment will be levodopa. It should be given in the early stages of Parkinsonism disease, where the motor symptoms, they will impact their quality of life. I told you earlier, I have given this kind of assignment. I have not seen anyone completing it. That is what is quality of life, and what are the parameters, what are the importance of quality of life. I could not see so far any such information from your side. I told this word will come very recurrently. I wanted to know how much you can study, how much you can go for. You can see so many articles on quality of life. So where the quality, where their motor symptoms are there and they are affecting the quality of life of the patients. So in that cases, levodopa is the first treatment. Then the dopamine agonist, levodopa or monoamine oxidase inhibitors can be given in the early stages of Parkinsonism, and where motor symptoms do not impact their quality of life. In that cases, we can use any of these three. But if there is a motor symptom which are affecting the day-to-day activity, or they are changing the quality of life, then levodopa should be the first line treatment. One should not offer the ergot derived dopamine agonist as a first line treatment for Parkinsonism disease. By the way, what are these ergot derived dopamine agonists? Anybody? Example of dopamine agonist which are, we call them as ergot derived one. Very good. So there are variety of ergot derivatives, and these ergot derivatives should not be used as a first line treatment because they have got so many adverse effects. So then always in that cases, because usually, as we have seen, these are the elderly people, and they have their difficulties in all the movements, including day-to-day activities. So it is great to give information to patients and their carers or family members. So that, and this guidelines actually informs to give oral as well as written information about various risks, including whatsoever adverse effects they can have, what care should be taken, and in that cases what should be done. Example of these are impulse control disorders with the all dopaminergic therapy, particularly more risk with the dopaminergic agonist. So there are recommendations are given how to monitor these impulse control disorders which are adverse effect of the dopaminergic therapy. Then there is excessive sleepiness and sudden onset of sleep with the dopamine agonist. So again, it can cause daytime sleepiness, so vehicle driving, etc., all should not be there. In some cases, psychotic symptoms like hallucination, delusions can be there, and particularly high risk with already dopamine agonist it is there. So again, for that non-motor symptom, we should go for treatment, because this is a really complications these people are having, because we have seen that if it is antipsychotic drugs are there, they have more chances to have extrapyramidal symptoms, and when the drugs which are used in Parkinsonism, they may cause their impact on dopaminergic related adverse effect, including psychiatric activities. So this has to be very finely managed, and therefore the guidelines has to be given. The other adjuvant treatments are there, then in various conditions we can give. That is, if the Parkinsonism treatment has developed dyskinesia or motor fluctuations, uh, we call it as on and off phenomena. Example in L-dopa, wearing off phenomena. So the specialist will guide in that, so that the drug treatment can be modified. So in that case, what should be the modified? Because we know that the causative drug here is L-dopa. So we can change it. We can give dopamine agonist. We can give MAO inhibitors or COMT inhibitors, which is an adjunct to this levodopa. For the people with the Parkinsonism disease, we have developed dyskinesia or motor fluctuation despite optimal levodopa therapy. So in that cases, they should take consideration of various things like patient's individual clinical circumstances, their Parkinsonism symptoms, comorbidities and risk from the polypharmacy. That is, polypharmacy means when more than one drug or one type of drug we are giving, then there are chances of having different kind of adverse effects simultaneously. The lifestyle circumstances, preferences, need and goal. Now suppose if it can be manageable for 1 or 2 days dyskinesia, then there is no need like that. But if it is really affecting too much, the lifestyle is affected, then yes, we can go for the shifting. The potential benefit and harm of the different drug classes when we are using for this, then we should aware about it and we should inform it. Now we have seen that the problem was there with the dopamine, the L-dopa. So we have seen that what are the drugs which are we can offer against this. These are the dopamine agonists, MAO inhibitors, catechol-O-methyl, that is COMT inhibitors, and amantadine. These are various drugs which are used for this. So motor symptoms, if dopaminergic agonists are used, I repeat, we understand it. We are doing this in what condition? When there is a adverse effect, that is wearing off effect of L-dopa has been there, and that is affecting the movement, that is changing the activity, affecting the routine schedule, and patients needs to be having another treatment, then we are going for this. So example of these are drugs are there which are we are using as a replacement to L-dopa for certain period of time. These are the dopamine agonist, MAO inhibitors, catechol-O-methyl transferase inhibitor, amantadine. Now in that cases, when we go for this, what are the effects we can see? So dopamine agonist can show good improvement in the motor symptoms which we have observed. MAO inhibitors will also show improvement. COMT inhibitors will also show improvement in the motor symptoms, while amantadine will not show much improvement in that. Now daily living activities, this all three, dopamine agonist, MAO inhibitors and COMT inhibitor, will show improvement in the day-to-day activities, and it will be good. Amantadine, again no evidence of they are there. Then off time, we know the on and off phenomena. That is, off time is what? Anybody, what is on off phenomena with L-dopa? Therefore, I suggested you to go through the pharmacology. Anybody, what is on-off phenomena? Okay, you can go. You can check it. You can read it later whenever you get time. So the drugs here, the dopamine agonist, MAO inhibitors, they will, and COMT inhibitors will cause, comparatively dopamine agonist will cause more off time reduction, while MAO inhibitors and COMT inhibitor will also cause off time reduction again, but it will not be as big as this dopamine agonist. Again, amantadine has not proven very beneficial in this also. Again, adverse events, we'll see that dopamine agonists are having more dopamine agonist as having intermediate risk of adverse effect. Intermediate means if we compare with L-dopa, they will be comparatively more. The MAO inhibitors are having fewer adverse effects. The COMT inhibitors, they are having more adverse effects. And again, very detailed data is not available about amantadine. Hallucinations, dopamine agonist will cause more hallucination chances. MAO-B will have lower risk of hallucinations, and similarly COMT will also have lower risk of hallucinations. So this we are doing. Again, we have seen that we are going to choose non-ergot derived dopamine agonist in most of the cases, because the monitoring that is needed with the ergot derived dopamine agonist is there, because ergot derived dopamine agonists are having multiple actions, and they are having comparatively more adverse effects, because if they are having multiple actions, then definitely they will have more adverse reactions. The ergot derived dopamine agonists are only considered as an adjunct to levodopa for the people with Parkinsonism disease. In what condition? That is, those who have developed dyskinesia or motor fluctuation despite optimal levodopa, and those whose symptoms are not adequately controlled with non-ergot derived dopamine agonist. Only in that conditions we can be giving ergot derived dopamine agonist. But again, we should be prepared to have comparatively higher adverse effects than other agents. If dyskinesia is not adequately managed by or modified by existing therapy, then we can add amantadine. We should not afford any anticholinergic to the people with Parkinsonism disease who have developed dyskinesia or motor fluctuations. Now again, this I was explaining to second year, and multiple time I tried to explain it to the students with therapeutics, that how therapeutics is much different than pharmacology. Now we are just taking slight inference from mechanism of action, but we are not giving any stress on mechanism of action or pharmacokinetics, because when we are learning therapeutics, then we know that we are aware about it, and we have to go ahead of that on the basis of their mechanism, their good things, their bad things, their pharmacokinetics, and everything. We are now reaching to the conclusion what should be used. And in addition to that, we have got another data with us, to what we call it as a class of recommendation and level of evidences. These two things we have seen many times. So in that conditions, we can discuss it, and for that we can have these guidelines made in therapeutics. So this is how the therapeutics is different. Therapeutics is more towards actually utilization of pharmacological knowledge for betterment in the therapy. Now what we are doing in next, so whenever there is an impulse control disorder is there, that is impulses are there and they are affecting. So these impulse control disorders, they can be developed in a person having Parkinsonism disease, particularly who is on any dopaminergic therapy. Any dopaminergic means, when we have seen L-dopa, that is which is increasing the dopamine levels. Then we have seen dopaminergic agonist is another thing which are acting on dopaminergic receptor, and third things are there, MAO inhibitors, which will increase the dopamine concentration by a reduction in the metabolism. So these three are the dopaminergic therapies. So there are chances that चलो all the best. So this is how the conditions are there, and in that we'll see that what are the risks which are associated, why there is a impulse control disorder, whether it is because of dopamine agonist therapy, whether it is the person is having history of previous impulsive behaviors, or in addition to this Parkinsonism, the person is having a history of alcohol consumption with or without smoking. So in that conditions, accordingly one can take, and this information will help the clinician to take the better decision. Whenever the dopamine agonists are started, again this all information, oral and written, they are very clearly insisting about NICE guideline, because there can be increased risk of developing impulse control disorder when taking dopamine agonist therapy, and this can be concealed by a person affected. The different type of impulse control disorders like compulsive gambling, hypersexuality, then binge eating, obsessive sleeping, or if you remember, we have seen OCDs, that is obsessive compulsive disorders, because these are the impulses. There are many such comes like bulimia, etc., etc. So there are many such things are there where impulse control are there. Suddenly they will have impulses, even theft, etc., stealing. Okay, these are various things which are there where dopamine is involved, and because of this dopamine, this kind of impacts can be there. So if it is there, then there should be a carer or relative should be aware about it, and they can take the care of people. They can take sufficient measures for that. Then so once it is guided, once it is there, then these patients can be observed accordingly by carers, relatives, and subsequently whenever any such episodes are reported, then one can take care about it. It can report to a specialist, and they can modify the treatment. Then managing dopaminergic therapy in people who have developed an impulse control developed. So in that case, what we will be doing? So when we understand that it has already been there, because we have seen earlier there are chances. So we'll discuss with the person and the family members how the impulse control disorder is affecting their life. What are the possible treatments, like either reducing or stopping dopaminergic therapy or modifying it with other one. And we have to match it. What are the benefits or disadvantages of reducing the or stopping the dopaminergic therapy? Because our primary aim is treatment of Parkinsonism. So if we have to judge it again, what is the best option for that, whether to continue and manage adverse effect or discontinue and take care of this adverse effect. So these are two important questions are there which has to be answered on that situation. So whenever the impulse control disorders are there, the dopaminergic therapy to be modified, but again, as we have seen earlier, the treatment has to be reduced gradually. Monitor the impulse control disorder improves, and whether the person has any symptom of dopaminic agonist withdrawal, then it should be done. Other specific cognitive behavioral therapy targeted at impulse control disorder, this will be better way. If by chance one can control it with the cognitive behavioral therapy, then this is comparatively better one, so that the person can be means this impulse control disorders can be controlled with cognitive behavioral therapy, that is counseling and taking care about it, and that there is no withdrawal of treatment, so that Parkinsonism is not affected. So this is the comparatively best suiting option. We have seen earlier while classification, initially it starts with the motor symptom and then it goes to non-motor symptoms, and there are many things which are associated with the non-motor symptoms. So let us see one by one what are the problems which are non-motor in nature, but they are part of Parkinsonism disease. Example of this is daytime sleepiness. So we can advise the people who are having daytime sleepiness or sudden not to drive, because we know very important, and it should be informed to the licensing authority, RTO we call it as about it, and so that there is no occupation or whatsoever. If the occupation is having involving any risk where attention is very important, example handling machine or staying near to the machines which are very risky, very dangerous one. If there is any or chances of accidents, mishaps are more in that conditions, it should not be there. Consider the drug like modafinil to treat excessive daytime sleepiness in people with Parkinsonism disease only if the detailed sleep history has excluded reversible pharmacological and physical causes. Women who are pregnant or who are planning to pregnancy should not take modafinil because again it has got impact on the this fetus. Every 12 months, the healthcare professional with specialist expertise in Parkinsonism should review the people with Parkinsonism disease. We are taking modafinil, particularly for excessive sleep. It is given. Rapid eye movement sleep behavior disorder. It can be there. Again, if it is there, one can use about clonazepam or melatonin to treat it. And if it is found that it has got because of certain drug which we have used, certain drug means dopamine itself. Then nocturnal akinesia, again levodopa oral dopamine agonists are used to treat nocturnal akinesia in people with Parkinsonism disease. If selected option is not effective, then we can think about the next subsequent line are there. Then other is rotigotine is the another one choice if the levodopa and oral dopamine agonists are not effective in so this is rotigotine. It can be used in that conditions where the levodopa or dopamine agonists are not useful. So this is an agonist of all this. Rotigotine is a dopamine agonist and it is acting on all type of dopamine receptors. So this is how we can go for. Next is orthostatic hypotension. When the person is having Parkinsonism disease and it has got developed orthostatic hypotension, then we can use various drugs for that. Check out what can be the reason, whether simultaneously hypertension treatment is going on. If it is so, then which kind of antihypertensive drug is being there. There are certain drugs which can cause this orthostatic hypotension or which can exacerbate it. Then there are various dopaminergic agents, anticholinergic agents, antidepressants. They are causing it. So we try it out, and if we can find the drug as a cause, we will try to replace it first. In that, if we do not understand exactly, then we'll or we cannot replace the drug, then we'll go for the drug like midodrine for the people with Parkinsonism disease, and orthostatic drug, so that this is the person who is not having orthostatic hypotension. I hope everybody remembers what is orthostatic hypotension. We call it as a postural hypotension also. So I hope it is clear, it's known to everybody. If it is not, then we can discuss sometime. If it is not contraindicated or it cannot be used or it is not effective or not tolerated, then we can use fludrocortisone. It is having cardiac risk and potential interaction with the other medications. Then this is actually this fludrocortisone is actually a steroid drug, but this is, we call it as a off-label use. Off-label use, anybody knows what is off-label use? Anybody knows what is off-label use? Okay, take this also as a assignment. You put it the information on group. What is off-label use? Okay. Then next is depression. We know that we have seen various treatment for depression. When we find any kind of depression activity in that, we can use this. Same is the case whenever we get any kind of psychotic treatments, we can like hallucination, delusions, etc. Then we can think about the changes in the medicines, check the details from their the patient's family member or carers, and if the person is experiencing hallucinations, delusions, then check the evaluation, make the evaluation of these drugs, and what can be the condition, whether apart from treatment, is there any other condition which has triggered it, or is there underlying problem which was there which is now exacerbated. Again, there are many conditions. Exacerbation is what? Already disease is there, maybe symptoms are almost not visible or mild or maybe moderate, and whenever we add certain thing into it, exacerbation means which were the symptoms which were not visible will now visible, which were mild it will become moderate, or those were moderate may become severe. So whatsoever existing condition will be there, that will increase. So there are chances of this exacerbation whether it is there, but that means there is underlying disease also. So that can be considered accordingly. General evaluation will help into giving it. The hallucinations and delusions should not be used if they are well tolerated, and simultaneously we can have cognitive behavioral therapy or any other thing, and it can be well taken care by the family members and carers, then no problem. But if it is still there, then we can reduce the dosage of Parkinsonism, anti-Parkinsonism drug that might have triggered hallucination, delusions, and on the basis of severity of symptoms and possible withdrawal effects, we can seek advice from the healthcare personnel, particularly having this knowledge about impact and what can be done in that case. Simultaneously, we can add drug like quetiapine to treat hallucination, delusion to people with Parkinsonism, but there is no cognitive impairment. If standard treatment is not effective, we can offer clozapine to treat hallucination, delusion. Again, it is something similar as we have seen it. Clozapine we have seen as a reserve drug in case of acute psychiatric diseases which are not responding to normal treatment. The lower doses of quetiapine, clozapine are needed than the normal conditions. So we are not going to use the highest or even middle dose. We will start with the lowest possible dose for that. Do not offer clozapine to treat hallucination, delusion in people with. We should not offer olanzapine in these conditions. And other antipsychotic medication like phenothiazine, butorphanol can worsen the motor feature, because we know that all typical antipsychotics, they are responsible for this EPS, that is extrapyramidal symptoms. So definitely they should not be used in these conditions. Then dementia with Parkinsonism disease, we can offer some cholinesterase inhibitor for the people with mild or moderate Parkinsonism disease, dementia. Again, very peculiar thing here we can notice that when we study pharmacology, we see what kind of drug. One kind of drug is anticholinergic agent. That means we wish to have the decrease in the cholinergic activity, and we use the drug which are anticholinergic classes so that we can block it. In a standard pharmacology book, you will get a chart, and that chart will show the treatment in two ways. That is, one is on the dopaminergic and another is on the cholinergic receptor. Here in Parkinsonism disease, if the dementia is starting, then we are using the drug, that is cholinesterase inhibitor. Why we are using? To increase the acetylcholine level. And in dementias, in all kind of dementias, this type of drug are found to be very effective. So example of these are rivastigmine, and other are donepezil, galantamine, and rivastigmine patches. The cholinesterase inhibitor, people with severe Parkinsonism diseases, it can be used. Again, these are the off-label uses. Off-label word is very commonly coming. It can be always there at many times. One can consider memantine for people with Parkinsonism disease dementia only if the cholinesterase inhibitors are not tolerated or they are contraindicated. So almost we have learned few of the drugs which are used in dementias. When we shall see dementia, I am very sure you will be aware about these drugs. Then next is drooling of saliva. So what can be treatment we can give? We know which drugs are used when there is excessive secretion. Anybody? Anticholinergic drugs. Very good, Pratima. Anticholinergic drugs, but which one? Particularly which are acting on periphery, which are not crossing or which are not reaching to blood, crossing the blood-brain barrier, because these are, and particularly those are which are having more selectivity on the M1 M3 receptors, that is on the glands which are there. So we can use these agents. The people with Parkinsonism disease, non-pharmacological management, particularly speech language management therapy is there. The good drug in that case is a glycopyrronium bromide to manage the drooling in saliva of people with the Parkinsonism disease. If treatment of drooling is not effective or not tolerated or contraindicated, normally it is contraindicated in the people with the cognitive impairment, hallucination, delusions or history of adverse effects with this, then we can refer to a specialist service for the botulinum toxin. That is, botulinum toxin is again affecting acetylcholine secretions. But again here it is very toxic and it needs to be done by very expert hand. Only anticholinergic medicine other than glycopyrronium bromide can be considered only if these two things are not working, and we can take risk of the cognitive impairment or problem in these people. Then we can go for atropine like agents, otherwise not. Then pharmacological neuroprotective therapies, there are no benefits of, means people say, we have seen earlier, again if you remember mechanism, we have seen that it is believed that initially there was increase in the dopamine secretion. We have seen that these dopamine vesicles were blocked, that is it's because of the synuclein and all. If you remember all this, we'll just make it a revision briefly. And because of that, dopamine is remaining out of the vesicles, and because it is remaining out of the vesicle, MAO will be destroying it. While destroying or while the metabolism of this dopamine, what will happen is this will cause release of free radicals or oxidative stress, and that will cause the destruction of the neuron. So it was how that we have seen. So people believe that if we can give some antioxidant agent, we can prevent this oxidative free radical induced injury. So, but it has been found that there is no effect of that. Do not use vitamin A because it has not found effective. Do not use coenzyme Q10. Do not use dopamine agonist as a neuroprotective therapies for that. Only you use it only for clinical activities. But dopamine means people believe that, I repeat again, if you studied this pharmacology well, I told you people believe that it is because of the dopamine. So when we are giving L-DOPA will be converted to dopamine. Dopamine will metabolize through MAO. While metabolized through MAO, it will again produce hydrogen peroxide and free radical, and again it may cause damage. So many pharmacologists believe that if this is the mechanism that can cause more damage to neurons, instead what we can do is we will not use levodopa, we will rather prefer to give the dopamine agonist. If we give dopamine agonist, then there won't be metabolism of this dopamine, no free radicals. If no free radicals, no more neuronal damage. This was the basic thinking, this was the rationale behind thinking, but it has not helpful. So no dopamine agonist or no MAO inhibitors, they are working as a protections. So there are many non-pharmacological managements can be there which can be done. What we need is regular access or regular control, regular observation on clinical monitoring, medicine adjustment, point of conduct for support, including home visits when appropriate, reliable source of information about clinical and social matters, so that we can reduce the worries of people. Physiotherapies and physical activities, particularly in early stage of Parkinsonism, the physiotherapist can guide certain exercises, and accordingly it can improve the movements and help in the patient. Offer specific therapies who are experiencing balance or motor function problem. There is one technique that is called as Alexander technique for people with Parkinsonism disease who are experiencing balance or motor function problems. So these are various physiotherapy and exercise or physical activities are there. Occupational therapies can also be done for that. That is occupational therapist with experience of Parkinsonism disease for assessment, education and advice on the motor and non-motor symptom. So occupational therapy can be given who are having difficulties with their normal activity. Speech language therapy, again experts are there who will explain to improve the speech if they are having some problem in the speaking difficult words. Then nutritions, again dietitians should be referred, or dietitian should be taken, that is into this clinical scenario, and the help of dietitian should be taken for that. So various activities are there. Important is vitamin D supplement should be there. It should be taken, and no other things are very important apart from that. Only protein and vitamin D should be improved. Then any diet which is interfering with the levodopa, then it should be again used cautiously. Then one more technique is there when our pharmacological therapy do not help much, then we go for the technique that is called as a deep brain stimulation, that is DBS. We have seen it earlier also, and levodopa carbidopa intestinal gel. So what happens in that, the people with advanced Parkinson, advanced means which has reached to very higher stages and which is now not responding much to the pharmacological treatment. So we can have intermittent apomorphine injections or continuous subcutaneous apomorphine infusion can be given in this patient. In this patient, do not offer deep brain stimulation to the people with Parkinsonism whose symptoms are adequately controlled by the best medical treatment. Only it can be done when the pharmacological treatment is not enough to control, or it is not controlling it. Levodopa carbidopa intestinal gel is available. It is recommended. Okay, so these are the gel, that means it will be continuously releasing levodopa carbidopa. Palliative means end stage. I told you, when it has reached to a certain level where it cannot be, then only the patient's relatives and carers has to be guided that it is almost now difficult to revert anything, and they should try to keep the patient as happy as possible, and accordingly all treatment which can be helping them, which should be useful them, should be there. So this is how we finish the guidelines which are guiding us for the treatment of this Parkinsonism. Here we finish Parkinsonism. Next topic you may suggest, if it is there anything in the neurological diseases. So far the first one we have finished. There are many in that. So whatsoever you can study and you feel it is appropriate for that, you can suggest me. Otherwise I will start whatsoever I can do the best. Take care and be safe.